Hello everyone, welcome to Ra Online. So this is our second installment in trying to understand a little bit more about peripheral neuropathies. In this installment, we are going to try to understand and know about the specifics of the various peripheral neuropathies that are there. Before going on to that, just a quick recap on what we've been trying to cover in our first installment, where we predominantly tried to focus on the pattern recognition in peripheral neuropathy. So, and that requires 7 main questions. What are they? The first question is, which system is involved? Are we looking at a sensory? Are we looking at a motor? Or are we looking at an autonomic neuropathy? More often, it is going to be mixed. And sensory is often predominant component in most peripheral neuropathies. Therefore, if you have patients with predominant autonomic dysfunction or a pure motor syndrome, then you'll have to reevaluate and see if it is neuropathy or not. If there is a predominant sensory component, it is most likely a peripheral neuropathy. Most peripheral neuropathies, or let me put it this way, most peripheral neuropathies are going to have a predominant sensory component. Now, when you have a pure motor syndrome, then you're going to think of, although motor neuropathies can be one of the differentials, you'll have to rule out, particularly when you have a pure motor syndrome with LMN features, you're going to rule out motor neuron disease, you're going to rule out a neuromuscular junction disease like myasthenia gravis, and you'll have to rule out a myopathy. Similarly, when you have an autonomic predominant neuropathy, in the previous installment, I'd even given you a mnemonic to remember it. What is that called? That is called pig had HIV. What does this stand for? This stands for, P stands for porphyria, I stands for idiopathic pandysautonomia, G stands for Guillain-Barré syndrome. HIV is of course HIV. Here H stands for HSAN, which is hereditary sensory autonomic neuropathy. A stands for amyloid and D stands for diabetes. Because HIV is of course HIV. So these are all the major differentials that should come to your mind whenever you have a autonomic predominant presentation. So the first question is, which system is involved? Second question is going to focus on the motor weakness. What is the pattern of the weakness? Is it symmetric or asymmetric? Is it proximal predominant or distal predominant? So most often axonal neuropathies are going to have a distal predominant picture, whereas most of the demyelinating neuropathies have a symmetric proximal and distal pattern of involvement. And third question is, what is the sensory involvement? So, what do I mean? So, which sensory modality is involved? Based on that, we will know which fiber is involved. So, if there is predominant loss of pain and temperature, we are looking at a small fiber neuropathy. If there is predominant loss of proprioception with the patient presenting with sensory ataxia, it's usually a large fiber neuropathy. Or it could be a sensory ganglionopathy where patients can present with a significant proprioceptive loss. The fourth question is, are there any UMN findings? Because if there are, we'll have to rule out a diagnosis of motor neuron disease. Fifth question is the temporal evolution. Is it an acute? Is it a subacute process like Guillain-Barré syndrome or radiculopathy or diabetic radiculopathy or Lyme's? Or is it chronic? Most of the peripheral neuropathies are going to be chronic. Is it relapsing, remitting kind of a picture, or does it have a monophasic pattern? So these are all the questions when trying to assess the temporal evolution. Sixth question is hereditary. So what are the clues to tell you it is a hereditary neuropathy? So I try to remember it with this mnemonic called FOLD. What does FOLD stand for? FOLD stands for, F stands for family history. O stands for zero. It is not O, it is zero. Zero sensory symptoms. That means there is hardly any sensory symptoms, which is quite in contrast to the significant sensory signs which are there on examination. So you will find that these patients have significant sensory neuropathy, but they hardly have any sensory symptoms. That is very typical of how these patients with hereditary neuropathy present. What does L stand for? L stands for the extremely long duration of these symptoms. Most often these patients have had these deficits for years together. And finally, D stands for various deformities. Deformities of the foot arch, deformities of the spine like pes cavus, flat foot like scoliosis. All these may be present in patients with hereditary neuropathy. So, is it hereditary neuropathy? Are there any of these FOLD clues to tell you that this is a hereditary neuropathy? And finally, does the patient have any comorbidities? Because if so, it makes the etiological workup very, very simple. The patient is diabetic, then diabetes mellitus is the most common cause of peripheral neuropathy in most of the developed countries. So, in that way, understanding the comorbidities will help you to understand if you're dealing with a acquired neuropathy like from diabetes, or is it a metabolic neuropathy which can occur in renal failure or liver failure. Or are we looking at a toxic neuropathy, or is it a malignancy associated neuropathy? So, from an etiological point of view, all this while we have been trying to understand neuropathies from a pattern recognition perspective in trying to understand whether it is an axonal or demyelinating, whether it is sensory predominant, motor predominant, or autonomic predominant. Now we are going to try and look at neuropathies from the point of the diseases in which these are. So from that point of view, you can look at neuropathies as hereditary neuropathies, as acquired neuropathies which can occur in various diseases, from diabetes to amyloid to metabolic disorders to autoimmune diseases. Then you can have these neuropathies which can occur in the context of exposure to various toxins. So toxic neuropathy, toxin related neuropathies, and finally you have these paraneoplastic or malignancy related neuropathies. So these are all the neuropathies that we will be discussing in detail in this session.